Gender is a pre-written book, and the plot is boring. Daughter, girlfriend, mother, wife, rip out the pages, staple them to your back, and start soaring. Pretty, quiet, weak. They will try to describe you with such things, but you will use their stereotypes and turn them into your wings. When you choose to challenge, gender is a pre-written book, but not all the girls' stories end the same way. 33,000 girls are forced to become child brides every day. 132 million girls are not in school, and their futures are balloons that they watch drift away. But you are the full stop to the story. You are the new sentence that takes it on a different road. When you speak up, you open your palms and you share the load. When you choose to challenge, gender is a pre-written book, but not all of the characters are included, like the First Nations women who stand as still as statues, always walked past but never acknowledged or seen, or migrant women whose culture stands like a skyscraper, and they're forced to burn down the parts of themselves society doesn't deem convenient, or refugee women who are treated with brutality when we should have been lenient. And you are there as the story unfolds, and you are faced with a choice. So choose to challenge. Gender is a pre-written book, and this is your chance to add your own chapter, to call out racism and sexism, and use courage to rub it out, to stand where the rest of the world has chosen to sit, to call it out at home, at work, at school, bit by bit, to scream where the world has chosen to whisper, not just for your daughter, your mother, or your sister. Let us choose to challenge. Gender is a pre-written book, and if you're listening to this, then your actions are the pen, your life is the paper. You are not the oppression of the past. I believe that you are so much greater, stronger, kinder. Choose to create history, not to be created by it. Choose to challenge.
Hi, I'm welcoming everyone. My name is Dolores Lyons, and I'm a member of WISDOM, which is a women's interfaith group here in Metro Detroit. And I want to welcome all of you to the first in a series of presentations and conversations under the banner of Race and ... That's race in education, race in housing, race and. You know, the COVID pandemic has revealed so many inequities in our society and in our world that needs our attention and our correction. Well, tonight we'll begin a three-part series on race and medicine. Our presenter is Dr. Jesslyn Anderson, who will provide a foundation to help us better understand these inequities and how they came about. Our moderator is Dr. Oveta Fuller, and WISDOM is so happy and fortunate to have her collaboration, that is, on our series through her organization, TrustMessengers. So this evening's program promises to be eye-opening, maybe a bit provocative, but definitely educational. Now, so that you'll understand how the program will go tonight, I will introduce Dr. Fuller, and she will introduce Dr. Anderson, and through her and Dr. Anderson will do her presentation and give us a picture of the systemic background to the health disparities we see today. Then Dr. Anderson and Dr. Fuller will discuss the issues, and we're going to listen in. However, you will have a chance to ask questions, and we ask you to submit your questions in the Q&A box, not the chat, but go to the Q&A box so that we can see them. And then Dr. Anderson and Dr. Fuller will try to answer them in the last 10 or 15 minutes of our presentation. But before we get fully underway, what is WISDOM? Well, I'm going to let the president of our organization tell you. Her name is Terry Weingarten, and she wears many hats. But just to name a few, not only is she serving as WISDOM's president, she is also serving her fourth elected term as the treasurer of West Bloomfield Township. She chairs and serves on several boards and committees, and among other things, she's a happily married woman to Howard for 26 years, and is a mother of two amazing daughters, Julia and Allie, and two fur babies, Joey and Zach. So I'm happy to see our sister, Terry. Take it away.
Thanks so much, Dolores. I'm so honored to be a part of this wonderful event this evening. Thank you so much on behalf of WISDOM, Women's Interfaith Solutions for Dialogue and Outreach in Metro Detroit. WISDOM was founded in May of 2007 by Gail Katz, a Jewish woman, Shahina Beg, a Muslim woman, and Trish Harris, a Catholic woman, who decided that it made sense for us to create space for peace with women speaking and discussing important issues from different religions. We now have had a program for many years called the 5 Women, 5 Journeys, where we have 5 women of different religious backgrounds, which could be our sisters from the Baha'i faith, Muslim, Buddhist, Hindu, Mormon, Latter-day Saints, Catholic, Christian, Unity, Jewish, or even those from other religious backgrounds that choose to join us on a panel where we talk about issues and get to know each other better and see the similarities and differences. And we find out there's a lot of similarities, by the way. We also do have a book called Friendship and Faith, which highlights 52 stories of women, mainly in the local area, of different backgrounds and their stories of friendship. It's a wonderful book. We hope that you'll consider buying it on Amazon, or maybe contact one of us after. And we hope that this is a nice introduction for you to our organization, WISDOM. As Dolores mentioned, this year we're really focusing on race and religion. We had a wonderful Black church program recently. Race and suffrage. We had a program at the Charles Wright Museum. And of course, tonight's very exciting topic of race and medicine. So I'm looking forward to watching this program with you tonight on race and medicine. Couldn't be more excited. Thank you so much. And Dolores, take it away.
Okay. Thank you so much, Terry. And okay, so now we've introduced our president. I'm going to introduce our moderator for the evening, Dr. Oveta Fuller. Dr. Fuller is faculty of microbiology and immunology at the medical school at the University of Michigan. And she is also an ordained minister in the African Methodist Episcopal Church. She's also a scientist who studies and teaches about viruses. In other words, she's a virologist. Through TrustMessengers, Dr. Fuller African countries and in the US on infectious disease prevention, and has done extensive research and work with HIV/AIDS. Currently, Dr. Fuller sits on the COVID Vaccine Advisory Committee that examines COVID-19 vaccine authorization or approval with the FDA. She received her bachelor's in biology and PhD in microbiology and immunology at the University of North Carolina, Chapel Hill. She is a recipient of numerous awards, including the J. William Fulbright and Ford Foundation. And in addition to all that, she is a wife, a mom, and friend. And I just don't know how you do it all, Dr. Fuller, but I'm so glad you're here. I'm glad you partnered with WISDOM on this project. And I just thank you for being our moderator tonight, and welcome.
Thank you so much, Dolores, and thank you, Terry. It is quite a pleasure to be here. I'm so excited. Of all the things that we've been able to be a part of in the last 6 months or so, this is one of the ones that I'm so excited about. And it's because it's actually a partnership of the interfaith group of wisdom, who I'm coming to know and love, and issues that are important to all of us in this country and globally. So I'm so excited to be here, so excited to be a part of this series, Race and Medicine. And tonight we're going to begin the trilogy. There are 3 parts planned to this. The first part tonight is going to give us a background, what we need to know such that we're all on the same page. There's a term called Sankofa, which is from the Ghana language, which means go back and get it. Go back and get it. So even as you're looking forward, you are realizing that the past is critical and that the past is important to understanding and moving forward in the best way to the future. The second part will be about COVID-19 and looking at the disparities there, as well as what needs to happen to end the pandemic around preventions and vaccines. And then the third part, we thought we'd do something unique and look at Indigenous communities, Native American communities, and health disparities that have been unveiled by the COVID-19 pandemic. So the dates for those second and third conversations, dialogues will be posted. And I'm really excited to serve as the host for those as well. So thank you to WISDOM and to the Trust Messenger team for this wonderful opportunity to discuss issues that are important to all of us, regardless of your race or gender or where you're from. So it is my delight tonight to welcome to the Generational Trauma Health Disparities discussion our wonderful presenter who presented earlier to the WISDOM group and had such great information that they thought it not robbery to redo it. So this is an expansion. Dr. Jesslyn Anderson is a nurse practitioner, a speaker, and a small business owner who values service, innovation, and excellence in all that she does. Her career in healthcare spans 22 years and has allowed her to serve in various roles within the healthcare industry to include nursing, leadership, IT, clinical faculty, and now she is a medical provider. She has degrees that include a Bachelor's of Nursing, 2 master's degrees, and her Doctorate of Nursing Practice, which she received from Chatham University. There, her research focused on breast cancer disparities in African American women, and I'm looking forward to talking to her in our dialogue about a little bit more about that. Her experiences give her a unique perspective and firsthand account of the health disparities in communities of color. She works full-time and also part-time as a clinical faculty at a local university where she teaches and mentors future nurse practitioners. She is a proud member of the Delta Sigma Theta sorority, where she serves her local community through various community service projects, outreach, and others. Her career, education, and speaking engagements continue to feed her passion for improving patient education, health outcomes, and addressing health disparities in communities of color. So she, in other words, is the right person for such a time as this. Dr. Anderson enjoys connecting the historical legacy of the U.S. with the current health disparities that plague communities of color. Why are we here? How did we get here? She challenges, and she'll do that tonight, all of us to consider how we view the current systems we live in, how these systems can be changed, and what is our part in changing it. So I want to welcome Dr. Jesslyn Anderson. She's also from Rock Hill, South Carolina, where she's joining us from tonight, and I'm from North Carolina, so we're good Southern girls at our heart. Welcome, Jesslyn. It's nice to have you here.
Hey, thank you. Thank you for the welcome. And I just want to say it is an honor to be here. For Miss Dolores, who invited me, she kind of kicked us off today. I just want to say thank you so much, Samina, Terry, all of you WISDOM ladies. I just want to say thank you so much for giving me this opportunity. Dr. Fuller, it has been a pleasure. I'm just astonished by all of your accomplishments, and again, it is a pleasure to be here. So thank you for that wonderful and warm introduction. So we can go ahead and get started. I'll pull up the presentation. So as I said, my specialty is connecting that historical legacy of trauma and the experiences that we had, those lived experiences of my ancestors, and why we see the health disparities that we see today. I'll give the presentation first. It should last about 30 minutes, and then me and Dr. Fuller will do kind of like a conversation where we're kind of talking back and forth and maybe bringing forth some additional things that I did not cover. Health is the most shocking and the most inhuman. So thank you. Again, Martin Luther King made this quote in front of the Medical Committee for Human Rights, and that was in 1966. Here, before I start presentations, I just like to let people know that sometimes presentations such as this can be difficult to hear. The information can be very heavy, but it is profound. And a lot of times it can be information that a lot of people have never heard before. So I always ask people to just keep in mind there will always be information that exists outside of your box of knowledge that we think we know. And we have to know that knowledge is power. So the more we know, the more we grow. And we have to remember that our knowledge, or what we call our present day knowledge, is going to be informed by our lived experiences, our communities, what we learned in school, and then where we are present day. So let's kick it off. We're going to talk about health disparities because that's what the presentation is about, generational trauma and health disparities. So what are health disparities? As here on the slide, we talk about health disparities being preventable, and that's the key word. So as I go through my presentation, you'll notice that I'll point out keywords because I'm a big language person, because language is important. Words are important. How we use them can inform decisions. How we shape language can shape laws, policies, and procedures. So language is very important. So health disparities are preventable differences in the burden of disease, injury, violence, and opportunities to achieve optimal health. They're unequitable, and they're directly related to historical and current unequal distributions of social, political, economic, and environmental resources. So what are some of the risk factors that they have found that contribute to these health disparities? They have poverty, environmental threats, health coverage, educational inequalities, but I always challenge and I say, well, what's missing? Let's talk about social determinants of health. So if you ever worked in healthcare, social work, or any type of what we call social services type of role, then you've probably heard of social determinants of health. These are what we call the conditions that make poor outcomes in healthcare. So economic stability. If you don't have economic stability, we know that the way that we are set up in the US, insurance is tied to jobs. So that can be a social determinant of health. Neighborhoods. Some neighborhoods are closer to what we call dumps, or some neighborhoods have been intersected by highways. There are food deserts. Education is important. We know that the more education that we have, we know that our healthcare tends to be better. Community and social context, right? What does your community engagement look like? Do you have social support? So when we talk about these social determinants of health, we also tend to use the terms marginalized, disadvantaged, hard to reach, underserved, underrepresented, and at risk, right? These are the terms that we use to describe populations, typically communities of color. But what I've noticed is when you look at the language, we rarely use the term left behind. We have heard that term, and typically we hear that term around economic anxiety, right? But again, I'm a huge language person, so we have to ask ourselves, when you hear the words marginalized, disadvantaged, hard to reach, it doesn't really say why, right? Because a person can be hard to reach because maybe they don't have access to a phone. But why don't they have access to a phone? But when we use the term left behind, it implies that an injury happened to a person, something happened to them, they were left behind. And because they were left behind, then we have a responsibility to bring them forward. And that is again, the language that you hear used around economic anxiety, but you never hear it used around social determinants of health and or with communities of color.
Jesslyn?
Yes.
Dr. Anderson, so you're saying words really matter, right?
Yes. Mm-hmm.
Okay. Just want to make that point now.
Okay. And so deliberate systems of inequities. So this is a term that I use most people use the term white supremacy. I do not use that term. I don't think it's an accurate term, and I don't think it gives the full scope of what we are actually dealing with and what we see. So what are deliberate systems of inequities? So deliberate systems of inequities are the way in which systemic structures, systems, and institutional arrangements work together to allocate resources and implement laws, policies, programs, or initiatives that have either created or continue to maintain racialized disparities and outcomes, often under accepted cultural norms of the time. So that is how I kind of define these deliberate systems of inequities. We talk about systemic structures. So what is that? They're foundational, they're organized, they tend to be interdependent, meaning they depend on one another to function. What are systems? They're organized collections of parts. They work together to accomplish an overall goal. So you have to ask yourself, what is the goal of the system? It tends to perpetuate dominant thinking. Disparities are often reinforced, and the biggest thing is they have the ability to erase gains. And we'll kind of get into that a little bit more in the presentation. What can be deliberate systems of inequities? It can be organizations, institutions, businesses, well-connected, wealthy individuals, because they have the money to influence. But what I like people to really understand is that government and law, those are what I call your most pervasive of all systems. And the reason why I call those the most pervasive of all systems is because if we implement a law in a state, then everybody is subjected to it. I know people have heard of the power of the federal government or the power of the state. So if the federal government implements a law, then it goes across the whole entire country, just like when they do taxes, right? So how are you taxed? That tends to be on a national level. So what I mean by that is we have to look historically and we have to say, okay, what type of government policies, programs, initiatives, or laws that were created that could have given gains to one group and erased gains or prevented certain groups from making gains? So those are the questions that we have to ask.
Dr. Anderson, I'm sorry, we didn't talk about this, but I'm going to just stop you a few times because I want people to really get this. So you're saying that the government and laws are part of the systemic system that has helped to set up the deliberate inequities that lead to the health disparities that we have now. Just want to make this point now because we're trying to absorb this and it's really very important.
Okay. And so the next slide, we're going to talk about what are those deliberate systems of inequities. They include education, economics, media, labor, law, health, politics, religion, and war. And just remember, war does not, I know most people when they think about war, they tend to think about violence or, dropping bombs or soldiers, but you can have what's called Cold Wars, right? So you don't have to actually be boots on the ground. It can actually be where you influence policies or you do things that will keep a particular continent, country, or whatever the case from making gains. So when we talk about generation, because we have to say my presentation is generational trauma. So when we think about 1619 to 1921, we're at about 402 years. The question is, how long is a generation? Usually a generation is going to be defined as about 20 to 25 years. I use 20 because that's kind of where we were, because the generation is going to be the birth of one generation into the birth of the next generation. And so here, probably within the last 40 or 50 years that women start having children later. But for the majority of our country, most women had children early 20s, if not younger. So I just kind of created a little slide here where we looked at a little bit of inflection points throughout history. It's a lot more than that. But what I want people to realize is when you think about 1619 and where those first 20-some odd slaves arrived in Point Comfort, and remember they were traded for food. By the time we got to 1700, we were already 4 generations in. And by the time we really got to the Civil War and where we said we started Reconstruction, we are already 12 generations into slavery at this point. The question is, what can be lost in 12 generations, not 12 years, but 12 generations? I also included Reconstruction, or at least when it ended, because Reconstruction only lasted 12 years. So when we think about one generation from the next, we always say say that the next generation should always do better than the first. Well, if you look at any point in history of time, African Americans only had about 12 years doing Reconstruction, and those 12 years were not peaceful. So they did not even have an entire generation to actually reset the trauma, to try to make gains within society, to try to set themselves up to improve further generations.
Okay, can you go back just a second? I'm sorry to do this, but I know that people are trying to absorb this, and you've seen it before, but most of us not really had the opportunity to really sit and appreciate this. So you're saying from the time of the first enslaved people from Africa that we know of coming as cargo in 1619 to 1865, which was when the Civil War ended, was 12 generations. Is that right?
Yes,
okay.
ma'am.
All right, just want to be sure.
And that's important because when you think about like the Geneva Conventions, you think about genocide. And the reason why, you know, there is policies and things around genocide is because what they found is, of course, when you strip families or when you take children and you put them into different environments, different cultures, you are essentially stripping their culture from them. So when Africans arrived on the shores here, remember, they could not practice their religion. They could not practice, well, of course, they had to speak their language, but that was even, they had kind of regulations on that. They could not teach their customs to their children, right? They had to, and we've heard this word because we hear it present day, assimilate.
Yes.
And so when we think about generational trauma, we have to ask ourselves, so this is how I define generational trauma. It's the mass cultural and historical traumas that extend from one generation to the next. The impact on these individuals and societies are often felt in multi-dimensional ways. And we have to remember there's what we call transgenerational effects, meaning from one generation to the next, and they tend to be familiar, psychological, neurobiological, social, cultural, and new research is also showing via gene expression, which we call epigenetics. And basically what they're saying is you can experience so much trauma that it can actually influence the way that you respond to trauma in future generations. It influences the way that we interact with our children. It influences the way that we interact with our spouse and family. So an example of this was during the times of slavery, because families were often split up and they wanted the best, you know, that's who they will auction off. Sometimes you would have Black mothers who would call their sons dumb, or, you know, say negative things, or tell said person that owns the plantation that their child is no good, that they're no good, they're dumb. And so that kind of still sits and resides because that's actually dysfunctional, right? But in order to protect her child, that's what she did. Another thing is there's the laughing barrel, right? I know people think about the laughing barrel, don't really think about it, but it actually has a historical context because slaves were not allowed to show emotions. So when they wanted to laugh, they would go and laugh into a barrel so no one could hear it. So we have to think about those things. Generational trauma, again, is often cyclical. Poverty, when we see generational trauma, compromised parenting, we just talked about that. Ongoing and repeated trauma, maladaptive and risky behaviors. And here I just kind of have 4 personalities that they say can come out of generational trauma, and that can be numb, where a person is just kind of numb. So much has happened, they're just numb to it. A victim mentality, like so much has happened to us, it's kind of hard to get out of this rut. Complacent can be, well, it happened, but you know, I'm just going to live my life and kind of keep my head low. And then fighter, I consider those people like what we consider our social justice warriors. I use this picture because, of course, and this is an actual picture. This is a gentleman that had been whipped, but you see the scars, and we have to remember that generational trauma, it leaves scars, and those scars we carry with us. Adverse childhood events. Why do I have this here? Because we talk about this present day. And so it's all about connecting the past to the present. And so what do we say about adverse childhood events? Those are the things that when people experience them, they have an increase. They have an increased likability to have dysfunction. So what are these 10 ACEs? their abuse, physical, emotional, and sexual, neglect, physical and emotional, and then household dysfunction. And if you look at these ACEs, you will realize that actually those humans that were enslaved experience all 10 of these ACEs. Now, when you get to mental illness and relative in jail, that's going to be seeing individuals actually enslaved. Divorce, that's going to be separation of family. Substance abuse, that was an issue. You know, slaves were not only were they allowed to go to church on Sunday, but they also were allowed to drink, and especially on holidays. So you did sometimes have some substance abuse with those individuals. But when we have these ACEs, these are the behaviors that can happen, and then the physical and mental health that can happen as a result of it. And this just kind of shows, this is the CDC and Kaiser ACE study, and it just shows that the more ACEs you have, the increased dysfunction. So you can see once you get to about 4 to 10 ACEs, then you see how you have an increased likelihood for smoking, alcohol, IV drugs, heart disease, attempted suicide. So we have to acknowledge that if we have that information now, and we had individuals that experience it, 10 ACEs, often on a daily basis for 200 and some odd years, then the present day dysfunction that some feel that they see, then it should not be shocking to anyone. But a lot of times we do not tie slavery with trauma. We usually don't even use those words in the same sentence.
Dr. Anderson, I got to stop you again. Sorry, we're using our dialogue now, so don't worry. So you're saying the adverse childhood events that people experience over the generations not only can have some physiological effects, but they are carried from generation to generation that then lead to some of these things that you have here on this slide.
Yes, ma'am. Mm-hmm. Yes, ma'am, including poverty. Poverty is another one. You know, we talked about that a few slides ago here, where we talk about the cyclical poverty, compromised parenting, maladaptive and risky behaviors, poor health outcomes, and actually shortened lifespan. So there was a study that showed that if you had at least 6 ACEs, that your lifespan could be shortened by 20 years. And if you look at it, African Americans have the shortest lifespan out of all races. So it's definitely tied there. Now to kind of get into what we really came here to talk about, which is kind of these health disparities and where do we get them from. So this is my slide that I have called Black Bodies Medical Horror. And so basically we kind of talk about some of the things. Now remember, this was 200 and some odd years. This is just only a small piece of what happened. But I just wanted to point out a couple things. Like in the 1830s, Dr. James Marion Sims, you may or may not have heard of him. He is considered the grandfather of gynecology. There's a number of statues to him, and he's actually from South Carolina. There's where he grew up. So what is he famous for? He is famous for operating on enslaved women. One girl he did over 30 operations on before he quote unquote perfected his technique. And he's also, no anesthesia. He didn't use any anesthesia because there was this wild belief that African Americans had thicker skin and they didn't show any pain. And if you think about it, right, so they just did a study back in 2017 where they talked to residents, first and second year medical residents, and that belief was still there. Over 50% of them thought that African American skin was thicker and that they could tolerate more pain. And this is present day. So this is how we see things and thought processes from the past that are still showing up present day.
I can affirm that. I've seen that study that says that very same thing that you said. So that's not something, not that I believe you made up any of this, but I just want to affirm that I've seen that and how shocking it is, because that's done in our DEI at the University of Michigan.
Yeah, and it is shocking because they're in medical school, right? So what you have to realize is that for 16 years, because by the time you get to medical school, you've done 12 years of, elementary, middle school, and high school, and then you've also done 4 years of college. And still, even after that, you still have individuals that are in medical school that think that. And what they found is it was 50% of those that are in medical school that think that way, but outside of medicine, 70% of individuals, and when they do these studies, they're talking about white Americans, tend to think that. So sorry, back to James Marion Sims. So he did, when we go to the gynecologist and they use a speculum, he is credited for creating that. Why do I have MUSC? Well, at the time it was called South Carolina Medical College, because the way that they advertised themselves was by having Black bodies that you could dissect on, because the healthcare system in the US started in the 1700s, so about 1770s actually. So this was the way to entice people to come to the school by letting them know that they would be able to have human bodies, enslaved human bodies to dissect. 1836, why do I have P.T. Barnum? So yes, that's P.T. Barnum and Bailey. So why do I have him on here? And that is because what he did was how his circus got started is he actually put a dissection. He did a public dissection. The enslaved person was Joyce Heth, that was her name. And he did this dissection on Broadway. It was done at the City Saloon, right in New York. He sold 1,500 tickets at 50 cents a piece. So you had 1,500 people that paid to come out to actually witness this. The 1840 census, the reason why I have this, because again, we're getting into government law, because what they did with this census is they wanted to go around and look at the health of everyone was not a slave in 1840, but they would look at those individuals that were not enslaved and those individuals that were. And what they determined by the census is that actually they are healthier if they're enslaved. So again, we have to remember that people have to justify what they're doing. Dr. Samuel A. Cartwright, the reason why I have him on here is because he was a physician and a psychologist, and he came up with the term, it's called drapetomania. So what that is supposed to be a mental illness that enslaved African Americans had when they wanted to run away. So there was a thought process in the 1850s, and it was introduced by him, that if those enslaved individuals wanted to run away, then something had to be wrong with them. They had to be mentally ill. And he is the one that brought that thought process out. Why do I have North Carolina Mutual Life Insurance Company? Because actually, in 1858, 75% of the life insurance policies were actually on enslaved individuals. So you had an insurance company, and they insured those enslaved bodies. Well, what they found is that they felt and that the plantation owners were sometimes killing the slaves intentionally to collect on the insurance policy. So what they did is they implemented, and they said, nope, you have to do a physical exam. And if those people that were enslaved were in what they consider riskier jobs, then, and I shouldn't call it jobs, but you get the gist of what I'm saying, that the insurance policy would be higher. And if you look, we still do insurance that same way. 1850s Medical College of Georgia, again, that was the stealing of African bodies and dissecting them. They actually buried them under the school, and that went on from the 1850s to 1913, and they actually ended up finding those bodies when they went to renovate the school. The Central Lunatic Asylum for the Colored Insane, it was the actual first mental institution that was created for Black people, and they were kept there, often killed, often sterilized. 1883, Francis Galton. 1915, Dr. Harry J. Heselden. So Francis Galton was actually the cousin of Charles Darwin. And so he coined the term eugenics. So eugenes mean good genes. And so that is where they're saying that we need to have individuals with desirable traits. And those that did not have desirable traits, the thought process at the time was to allow those individuals to die. And if help was needed, then that was okay as well. And that is what Dr. Harry J. Heselden was famous for, because he would allow what he considered to be defective infants. He would allow them to die at birth instead of trying to give them any type of life-saving measures. Most people are familiar with the Tuskegee syphilis experiment. Do know that this went on for 40 years. Understand that this was a partnership with the United States Public Service, the CDC, and HBCU. They were all, and HBCU means Historically Black College and University. They were all in this study together. It was ran by Thomas Morrell. And I just want to kind of read what he stated. So he refused to treat these sharecroppers. There was about 400 sharecroppers. And what they did was these gentlemen had syphilis. And instead of treating them, they would give them aspirin, multivitamins, things of that nature, but they never would treat them for syphilis, although there was a penicillin was found in 1940s, 1950s. So there was a cure, but they refused to cure them. And the only reason why the study stopped in 1972 is because there was a whistleblower that leaked it to the media. And that is the only reason that it started. But I want to read what he said, because now this was Thomas Morrell. He was a public health service physician. He worked for the government. And this was his thought process. So this is the person that is over this experiment. He said, the future of the Negro lies more in the research laboratory than in the school. He said, so the scourge sweeps among them. Those that are treated are only half cured in the effort to assimilate. A complex civilization drives their diseased minds until the results are criminal records. So basically he was saying there's really no point in treating them because they're going to be criminals anyway. Perhaps here, in conjunction with tuberculosis, will be the end of the Negro problem. Disease will accomplish what man cannot do. And so again, when people are over organizations, programs, initiatives, and if that is their mindset, then they're not going to have the best intentions of those individuals. And actually, because of this experiment, because it was so wide ranging, that is why now when you do research projects, you have the Institutional Review Board. There was a lot of changes that came about because of this study. 1933 North Carolina Eugenics Commission. You may or may not have heard about this. Again, this kind of goes back to Francis Galton, and basically what they were doing was sterilizing women if they felt that you were mentally ill, mentally incapable, Black, then often you were sterilized. And they said by the time in North Carolina, by the time that this finished, they had sterilized some 7,000 odd women. Henrietta Lacks, why do I have her here? So we're talking about HeLa cells. This was actually at Johns Hopkins Hospital. So yep, her cells.
I've used HeLa cells in my research before, and they're very sturdy, very useful, very widely used cell lines.
And I'll tell you all the things that it's been used for. So if you are a woman, you've ever had breast cancer, or you know a woman that had breast cancer and they've ever been on tamoxifen, then you have her cells to thank for that, because her cells are the basis for that. So her cells have been used in cancer research, AIDS, the effects of radiation and toxic substances, and AIDS. That would explain why Dr. Fuller said that she's used them before. Gene mapping, testing human sensitivity to tape, glue, cosmetics. It was crucial in the development of polio vaccine. So again, you have African-American woman. She was a sharecropper. She went into the hospital. She had ovarian cancer. They took her cells, shipped them around the world, have made billions off of her cells, and her family has yet to be compensated for that.
Dr. Anderson, two things. There's some background noise, and we're figuring it's probably something you're doing that people are hearing. So I don't know what's rubbing up against your mic, but also just know that the Henrietta Lacks story, there are many cell lines that are transformed from human tissue that people get in biopsy or that sort of thing. So hers isn't the only story like that. It's just that they're so widely used. And when the family found this out, they were not given any sort of acknowledgement that this was where those cells came from. That's what the issue is. There are many other cell lines like that as well.
Okay. And then 1960, University of Cincinnati, why do I have them here? And that's because they contracted with the Department of Defense to perform radiation experiments on poor Blacks with cancer. So that's just some of the things that has happened. And I started in the 1830s and came up very close to present day, just so people can understand that a lot of these things are not 200, 300 years old, but they're actually 50, 60, 70 years old. This is what I call historical inflection points in the system. And so I'll just kind of point out a couple things. Again, we talked about the first US medical degree, so that's 1770s. That is why you've seen such rampant medical experimentation in the 1800s, because again, the US healthcare system had just kind of started. So these doctors, they needed to experiment, they needed to dissect. We're going to use those people that we consider undesirable, those individuals that we have dehumanized, and that is exactly what happened. 1847, David Peck, so that's Rush Medical College in Chicago. He's actually the first US physician. I put this up here because you can see there's about 77 years between the time that we had our first white physician and the time we had our first African-American physician. And during that time, African-Americans could not go to medical school in the South. So that is why he actually graduated from medical school in Chicago. 1849, you have the American Medical Association was started. 1895 is the National Medical Association because they would not allow African-American physicians into the AMA, so they had to create their own. I have 1865 here. So prior to Reconstruction, we had no medical schools. And when I say we, I mean African Americans. There were no medical schools that trained African Americans. During that short period of Reconstruction, we actually opened 7, right? With, I believe, Howard University or Meharry, I can't remember, but one of them was the first medical school. 1904, Council on Medical Education was created. 1910, that is a very important date because what happened then that the AMA, they published what's called the Flexner Report. And at that time, what they did is they went around and they looked at, it was like 148 medical schools, and they said, okay, medical schools should have this type of education. They should have these type of resources. They should be connected to a hospital. So basically they implemented a ton of rules and regulations. And if you wanted to remain open, then you had to follow those rules and regulations. Now, at that time, Leonard University, which was a HBCU medical school, was the only 4-year medical school that was in the US at that time, and they actually produced more African-American physicians than the other 6. So they were graduating African-American physicians at a much larger rate. But for some odd reason, they were one of the medical schools that was pinpointed to close. So what ended up happening is once they issued that report, by 1923, there were only 2 HBCU medical schools left open.
Wow.
Yeah, and the reason why I say that that's important. So we have to ask ourselves, in 1910, 2.5% of US physicians were African-American. In 2020, only 5% of US physicians are African-American. We went from having 7 HBCU medical schools to only having 4. Right. So we opened 7 up in a span of Reconstruction. So from about 1865 to about 1900 total, but we've only been able to open 2 because of those stringent qualifications and rules and regulations that you have to follow. Actually, in what, 100 years? They've only opened 2 in 100 years. Let me actually read this. So I have the AMA statement here from Dr. Madara. So here in 2008, the AMA, they concluded a 3-year study on this is his statement. So I'm reading his statement.
Okay.
On the racial divide in organized medicine, and publicly apologize for our organization's past discriminatory practices against Black physicians. The AMA's apology was never intended to be the final word on the subject of race for our organization. In fact, the AMA called it a modest first step toward healing and reconciliation. This is a journey of reflection and action that continues. As we grapple with AMA's 174-year history, we must acknowledge that decisions by AMA leaders contributed to a healthcare system plagued by inequities and injustices that harm patients and systematically excluded many from our physician ranks. In 2018, our AMA House of Delegates adopted policy and strategic framework for addressing these health equities on a national scale. So let's talk about the heroin epidemic. And the reason why I bring this up is because when you look at the healthcare system as a whole, and you think about what has happened, we did have something called the cocaine epidemic. And so we have to ask ourselves, what happened in the 1980s and 90s? We had a 3-strike rule. We had what we call mass incarceration. There were no treatment programs. individuals were called crackheads. The babies were called crack babies. And so again, we're getting into language and labeling. And I know if anybody is old enough, they probably remember the show Cops. So you had media that played a part because these cops were going to communities of color, and, you know, of course they were chasing down drug dealers. And, you know, if you just remember Cops, you kind of remember what was happening. So when fast forward to 2000, started happening around 2000, but it was kind of recognized around 2010. In 2015, there were two researchers out of Harvard that published a study and said, hey, you know, we're seeing what we call deaths of despair. Now, again, we're talking about language. So these deaths were called deaths of despair. And what they said is, we have individuals, and they were tended to be middle-aged white Americans that were using drugs so much that they were dying at an accelerated rate. And that's when they said that it was probably tied to economics and those kind of things. Now, we can talk about economics because that data does not bear out. But when we talk about the system, we have to ask ourselves, what did we see changes in when it came to the heroin epidemic? We saw changes in politics on a local, state, and national level. We saw changes in law. We saw changes in healthcare, right? Because it was no longer a criminal justice issue. It became a healthcare issue. Mental health and substance abuse treatment centers. We've seen where drug companies have come out with new drugs to treat drugs to kind of help these individuals get off drugs. Pharmaceutical companies, right? We're suing pharmaceutical companies and making them actually pay the families. Language and TV specials. We didn't see cops. What we saw was mothers on TV saying that they were devastated and showing individuals injecting, but there was a lot of sympathy that was around it. The insurance industry. Most people don't understand why we call it accidental overdoses. Well, we call it that because we changed the language so insurance companies would actually pay out insurance policies, because before they would not pay out insurance policies when individuals were overdosing. So that is why we have the language accidental overdose. Drug war, where we don't have a drug war when it comes to heroin. We actually have drug courts. Right? Policing is not the same. You do not see police running in these middle class and very affluent neighborhoods in the same way that they did in communities of color. Decreased no drug testing across the country. Now, of course, there are still some companies that drug test. There are a lot of companies that have gotten rid of drug testing. And I want to read a statement by former FBI Director James Comey. And this is what he said about drug testing. So he was talking about, basically they were talking about, how do I find talent? So he said that his agency was actively revising its employment rules, which now say that anyone that has smoked, used any drugs in the last 3 years are ineligible. And they wanted to know why. And so what he said was that you're unable to get the best and the brightest if they are using, if you exclude those individuals that are using drugs. Now, this is from the FBI. So the idea that he felt that the best and brightest use drugs, and that the only way to get them was to do away with doing drug tests. When we know that drug tests creeped up in the 1980s, 90s, and 2000s to actually deny many individuals jobs, promotions, and those things. So I just kind of like to make those differences and then show that how the heroin epidemic actually moved in all of those systems. They changed labor, they changed healthcare, they changed laws, economics. You're not going to have the same economics because those individuals are not going to jail, correct? Because we know that if you take the father out of the home, or if you take the mother out of the home, then now we're dealing with an economic issue. Media, again, the different TV specials, if you think about Cops versus the TV specials that we see now. So, and we're not calling it a drug war. We're not calling it that. So those are just some of the things to kind of think about. Yeah, so when we talk about social determinants of health and we look back 100 years, we have to ask, why do we have the social determinants of health that we have, that we see in housing, that we see in education, that we see in healthcare? Again, the New Deal, our New Deal programs, a lot of those programs, African Americans were largely excluded from them. That was actually the conversation in Congress, that your Southern states kind of got together and said that, hey, we will approve Social Security, we'll approve certain things if African Americans are excluded. Your FHA, a lot of people wonder, where does redlining come from? Well, redlining was a government policy. It was written into the handbook, the Southern Strategy. A lot of people may or may not be familiar with that. I would suggest listening to Lee Atwater's interview. He has an interview where he explains this thoroughly about the Southern Strategy. And he basically says that, you know, in the 1940s and 50s, you could get away with saying the N-word, but as we got into the 1980s, 70s and 80s, then you have to change your language. And that's why I say language is important, because he said the language that we're going to use is going to be tax cuts, forced busing. And we still hear their language today. The war on drugs, college tuition. African Americans carry the highest debt out of all races when it comes to college debt. The 2008 recession, we African Americans have not recovered from the 2008 recession in the same way. Well, actually, no race, Hispanics or African Americans, have not recovered from the recession in the way that white Americans have. I put voter ID here because that's important. Voter ID technically changed the 2010 election. It really did. And that is why we ended up seeing some of the laws that we see now, and why a lot of the state houses were taken over in the way that they were. We just talked about the housing and job recovery from the 2008 recession, wealth inequality, and I do have a slide on wealth inequality, and we can kind of look at it as we're doing the Q&A. And then COVID-19, we know that COVID-19 has really, as Dr. Fuller said, shown the health disparities that we have. And we've actually gone from voter ID to now we're talking about voter integrity. And so again, now we're dealing with language and how language is changed. And it's what I call contortionist language, right? Because people will twist their language, twist, turn, maneuver, do backflips to use whatever language they need to justify what they're doing at the time. And because they, you know, voter ID was an issue, now it's voter integrity. Well, why was that not talked about when we discussed voter ID for the last 5 to 6 years? So those are just some things that I just kind of wanted to point out, and that's just the last 100 years.
All right. Well, thank you for taking us through that. Wow. So to know where you come from is required to know where you need to go. And this is what we're hoping will happen with this particular event tonight. Let's just do Jesslyn and Oveta. We're talking here, okay? So that just makes it easy. So Jesslyn, first of all, thank you so much for sharing that. And I just have a question for you before we talk about some of the details. Was this part of your dissertation? I know that you talked about your PhD. How did you get this sort of level of information? And this is something we all need to be aware of so we know how we got where we are. So just tell us a little bit.
So when I was doing my dissertation was on African-American breast cancer disparities in African-American. Well, as I'm reading the research, I'm noticing that the disparities that we saw in African-Americans were not lining up with the guidelines. So for example, although African-American women do not get breast cancer at the rate that Caucasian women do, they actually often catch it at a younger age, so less than 40, and it tends to be very aggressive, what we call the triple negative breast cancer. So as I'm reading through, and I partnered with Susan G. Komen because I put on a number of classes to kind of teach those things as well. Well, when I partnered with Susan G. Komen, they were like, oh, well, we don't teach self-breast exam. And I'm like, oh, that's weird. You know, and I said, okay, well, you know, after doing the research, I'll teach that piece. I said, because it's important, because we have to remember 40% of breast tumors are found on self-breast exam. So my question, as I'm looking at the data and I'm saying, okay, We're not doing mammograms until age 40. We're no longer encouraging physicians to do self-breast exams when patients come in. We're no longer encouraging patients to do self-breast exams. Then yes, African Americans are not catching breast cancer, and it tends to be late stage when they catch it. And so we have to address those disparities, and then we have to ask ourselves, why does testing not start to 40? And so what ends up happening is you look at the data, the testing is actually based off Caucasian women. And so those are the kind of things that we have to look at. So anytime I do any of my breast cancer teaching, I stress, please, please, please do breast self exams, because it can literally save your life, especially if you're an African American woman.
So this was part of your following through with how we got to some of the policies that we got. And by the way, let me invite our participants, our attendees, to put questions into the Q&A. Jessica, Dr. Anderson, and I are going to chat a little bit. And you can call me Oveta if I can call you Jesslyn.
Okay.
Or maybe we should stick with the formal thing here. But we invite our attendees to put questions into the Q&A such that when we get to that part, we can feed those in. I think it's open, and if somebody will just type something there, we can be sure that we can see it. If not, I'm sure the technical people will help us figure out where the questions are. So when we talk about COVID-19 and we see what happened, particularly early on, where, for example, in Michigan, 14% of the population is African American, but some 40% of the deaths by May of 2020 were due to, were in African Americans, of the COVID deaths in Michigan. Or I had friends who wanted to get a COVID test because they were feeling some of the symptoms, but when testing was so limited, they were not able to get a COVID test because they would call in or talk to a health practitioner who would say, well, you only have one symptom, or you don't have the right symptoms. So we only have a few tests, so we're not gonna, go home, and if you get worse, call us back. Now, when they got worse, they showed up at the emergency room, and now it was really in a very desperate state. So this is the background. What happened with COVID is that it revealed the same disparities that we've been seeing in cancer and diabetes and heart conditions. And somebody says, I'm just so sick of hearing Black folks being the ones, or African Americans and people of color being the ones who have poor health. And so what you've laid out is that this generational trauma that we have experienced since 1619, and nobody really wants to go back and get it, but we have to go back and get it if we're ever going to solve this. I've said that if you have something that's wounded, you can't heal it until you open it, reveal it, clean it out, and then repair it. And so how do you think that what you have shared affects what we need to do now? Clearly, I hope with the things that have happened in 2020 with the pandemic, unveiling anti-Blackness, unveiling health disparities, unveiling police violence, and so many other things, that we will go back, open it up, and have those difficult conversations in order to begin to change things forever.
And I think you're absolutely correct. So remember, our history informs our present, right? And our perception of history informs our present. And you have some people that are going off history, and if the history was they were lazy, dumb, feeble-minded, no good, all of those stereotypes that were in the 1600s, 1700s, and 1800s, you hear them today. You really do. And so we have to ask ourselves, the health disparities too, the 1600s, 1700s, 1800s, you still see those today as well. And so we knew that COVID was going to have these disparities because we saw that individuals were dying at a rapid pace. And anytime that there's this saying that if white America gets a cold, Black America gets the flu.
Yeah,
and so that's kind of what happened with COVID, right? We really had the flu technically. And so you saw these disparities. But one thing that I like to point out when we talk about COVID too is because, again, It matters, decisions matter, government policies, initiatives. So what ended up happening is when COVID first hit, there was this thing that the China virus, you heard that. So again, we're
Yes.
talking about language. So what happened was the prior administration, they shut down, they said, yep, we're cutting off travel from China. Okay, well, that was fine. But because there were certain thought processes there, they continued to allow travel from Europe. Well, then what ended up happening is when they looked at it, after 2 or 3 months, they found out that there was a deadly strain that came out of Europe, and that's what's happening now. And so that is why New York, so if you remember, COVID started in LA. Remember, that's where the deaths initially started. Well, that was what you call the Wuhan strain, the strain that was from China. The strain that hit New York was the strain
from Europe.
Yeah, it was the strain from Europe.
So
and
we shut down China, but we left Europe wide open. And that's
open.
Yeah.
And that is where that strain is circulating now. And that's the strain that the CDC director is actually concerned about right now, because it's starting to creep up. They're not sure if the vaccines are going to work against it. So this is why when we make policies and we make decisions, that we have to make sure that it's based on science and it's not based on racism, opinions, thoughts and actions that have informed prior decisions.
So when you say that, when people say things like they've said in the past, now people may not say those things out loud, but they can't be so far removed. They can't be removed from people's, in particular majority people who are currently majority people in the US, from the mindset, because that experiment that you mentioned about tolerating more pain because African Americans have thicker skin, that study wasn't only done with white medical students. Even the African American students thought similar things. So we're living in a society where there's so much systemic undergirding that all of us fall prey to it. You mentioned the cocaine epidemic versus the opiate and heroin epidemic. So one is taking out people, the other one is taking out people, but now it's a medical condition instead of a crime. So that's an example of the underlying bias that says if it's these people who have been enslaved in America and have that history, then it's one thing, it's a criminal act. If it's these people, then we need to change the drug rule such that we no longer do drug tests, because if we do the drug test, we're going to have people fail that test, and then we won't be able to get the best and brightest, because the best and brightest are using drugs. So this is, I just want to paint the reality for people that we see what happens with things like the George Floyd murder in Minnesota, and we see things like the bird watching in New York, and we see these implicit underlying assumptions that are so prevalent in our society, and I don't know how we change them. I don't know how we address them.
And honestly, it's going to take awareness, right? So awareness matters. So are you open to being aware to what you see? So for example, when you talk about African Americans, and African Americans can tell you this, so there's sometimes this suspicion when large group of African Americans get together. Well, that's rooted in the Virginia colonies, right? They actually made a rule. There was a law that said that, and it happened after Bacon's Rebellion. And they said that it was against the law for African Americans to gather in large groups. So the reason why I like to point out history is because you would be surprised how much we carry present day of thoughts, opinions, actually racism that was formed in the 1600s. When you talk about George Floyd and the killing of him in those 9 minutes that a lot of people remember, if you go back to the Virginia colonies, you had what was called the Casual Killing Act. Yes, and what the Casual Killing Act say? The Casual Killing Act said that if I correct you, right? So it was a correction. Yes. And if you resist, so see, you had your resistant language back in 1600. If you resist and I kill you in the process, then I'm not to be charged, I'm not to be blamed, I'm to be set free. That was a law. And it was updated 4 times.
A government law in Virginia. I'm holding up this book for 400 souls. That was, it's got 80 stories from 1619 to 2019 about what happened in America. Very short essays. I recommend that everybody gets it. 400 souls, Ibram Kendi and Keisha Bland, 400 souls. Somebody can put it in the chat. Because when you see what really happened, I was reading about, I've heard about slave codes all my life. But when I read about just how amazing those slave codes were, I'm just like, really? And you expect us to have recovered? We expect us to have recovered in this short amount of time. I was also looking at, I was preparing for a talk, and I was looking at the cumulative net worth of people in America. So white Americans' cumulative average wealth of a family is about $750,000. You include everything, assets. Average African Americans, at least on that graph, was about 120,000 or less. That's a huge gap. And so what has happened is these cumulative things over the course of 400 years not only affect income and housing and economics and health and nutrition. There's a question in the chat about diet and nutrition. When we were raising our foods, and lots of us brought the agriculture with us from the African continent that changed America, but we've never been given credit for that. There were so many inventions that were made because of the necessity to make work life easier for those enslaved people. But could they apply for a patent? No. So who did the invention go to? They went to the slave owner who could do that. So how do we take this information? We have to make it known. We have to go back and get it, and then use it as positive fuel to have the difficult conversations, to choose to challenge, to tell the truth in love, to have sessions where we're at the table and we can speak out in order to help all of the society make the changes we have to make. And I don't know if you have the answer. I'm just putting the question out there.
Well, I think that one thing I said is racism and what we call deliberate systems inequities, they are far more pervasive than we realize. And what we're dealing with present day is largely historical disparities, right? And so basically what you're talking about is a compounding, right? They just keep growing and growing and growing. It's almost like a, a snowball that kind of starts and now it's just out of control. But one thing that I know, and this is true, individual racism is important because I never say it's not. But I think the issue with when we think about racism, because of the way history is taught, we tend to think what happened in the civil rights movement. So we tend to think, policing, we tend to think KKK, burning crosses, the N-word, very, very vulgar, nasty racism. And what we have to realize is that racism persists in many, many ways, in many, many forms. And the most pervasive of it is actually subtle, right? It's very subtle. It meshes into society because society has been built that way. And so I am a firm believer that federal, state, local government laws, policies, programs, initiatives, and spending created the disparities we see. And the same thing will be needed to provide equity to communities of color. There is no way, when you think about the New Deal program, we have to remember that there was a Great Depression in the 1920s. So a large amount of wealth was wiped out of white America, and that is true. And so a lot of times the ghettos that people talk about today, white Americans stayed in those very homes. And what happened was the government actually created those homes for them that came out of the New Deal, right? They kind of gave them subsidized housing. And so ghettos, what ended up happening is when you had quote unquote what we call white flight, and when we moved to FHA, so now we're going to actually subsidize homes. So we're not going to put you in apartments anymore. We're not going to put you in these crowded living conditions. We're actually going to subsidize your homes. And so when you talk about Levittown and about 15,000 homes that were built out of Levittown, and the federal government subsidized those, that was in the 1930s and 40s. So what ended up happening is you had Social Security that African Americans could not get, because the southern states said that, yes, we'll approve Social Security if certain types of workers were kept from getting it. Well, then of course those workers were predominantly African American. So you had Social Security, you had the VA, you had the GI Bill, you had subsidized housing, and all of those things created the wealth that we see in white America, in addition to what we call the Homestead Act of 1865. So when you think about the Homestead Act, there was a study done in 2000 that when they looked at it, 46 million, or what we call 20%, so 1/5 of white Americans could trace their current, meaning in the year 2000, their current land and wealth to the Homestead Act in 1865. So that is almost what, 100 plus years later, almost. So
your generations thing, that's at least what, 9, 4, 5, 6 generations?
and that is why one generation can do better than the next, because we're passing down. So those homes that were created, that the FHA subsidized for white Americans, because in the redlining codes, those homes could not be sold to African Americans. And when those homes can be purchased at a couple $1,000s, because that's what the price of homes were. But one thing about homes is they last for decades. And so what was $8,000 in 1930 or 40, by the time you get to 1960 or 70, the price is going up. The home is paid off. You can take wealth out of your home. Now you can pay for your child to go to school. You can pay for
college.
to go
That's
to
right.
college.
Or you can go to
start
a
a
bank
business.
and get a loan on the mortgage, on the value, the equity in your house to educate your children. Yeah.
Exactly. And then we are making African Americans mostly renters. Right.
Yeah.
And we know what renting is not stable. There's no equity you can get out of renting. And someone can decide at the last minute they want to go up on your rent. And so that's what we're seeing with gentrification, right? People are coming in homes that were $20,000 for 40 years. Now within a year are worth 150. And so you have to think about that. You have to think about that.
These are things that we're not bringing these up to make anyone feel bad. We're bringing these up to get to the truth so we can make it better. There are some questions that we do have in the short amount of time that we have. Mm-hmm. One person says, from the beginning of your profound historical discussion, I thought about the tax and mortgage systems, which is what we're talking about. Mm-hmm. As wondering, how do you see structuring reparations to correct or address these disparities? Or how do you see the greatest change impact happening, policy or what? What is going to make a difference? And Dr. Anderson, any thoughts on that?
So again, it's going to be policy, right? Now there's some discussion. I cannot remember her name, but I have read a few of her articles. She's actually doing research on the tax code. And what she's realized over the last 100 years is that the way that the tax code is shaped, it actually favors certain individuals. And that is not just white individuals, it's primarily wealthy. Income. Yeah. But the issue is that most of your wealthy individuals are your white individuals. So that is the tax code is definitely going to have to be changed.
So I have an answer. Mm-hmm. The vote, what happened in Georgia changed what is going to happen in the Senate. So those sorts of things, the local and national elections are critical because it's the government that changes, that has the power. State and national government and local government have the power to vote in policy and governmental change. So the Me Too movement that moved women into power, into political seats, because they chose to challenge the things that happened with Stacey Abrams. So we've got to protect the vote. We've got to continue to keep our young people, our young adults active in that energy. Actually, well, let me actually ask the next question. Because we only have a little bit of time left. Do you believe healthcare and education should be paid for by our government that we pay into? And that may be a bigger question than we can answer here tonight.
I do believe that we should go to more of a socialized type of medicine. I see too many disparities for no reason at all. We have to realize that the reason why our drugs cost so much is because we subsidize drugs around the world. Those companies does not change. Pfizer operates in North America, South America, England. It's the same Pfizer. And so we have to realize that, and I just say Pfizer because that's just one company I could think of, but these drug companies operate in different countries. If you go to Mexico, ibuprofen is called Vixen. You can get it over the counter. So
very different costs.
Yeah, very different material.
And we got to close out. Our last question, so what, and I'll answer this after you answer, and we need to keep it short so we can end on time and honor people's time who's here. We're so glad that we had this discussion to open up what where we're going to with looking at COVID-19 and other health disparities, to look at race and medicine and what we can do to begin to change some of these scenarios. So the question is, speaking out is so important, given the perspective and information you have provided. When we encounter vestiges of racism, we need to speak out. It helps to have these facts to present. How do we speak out in a way that engages people rather than makes them feel guilty and run away? We want allies. Everybody needs to work together to change what hurts everybody. Dr. Martin Luther King says, if one person's not free, then no one's free. So we're in this thing together. We'll learn to live together as brothers and sisters, or we will die together as fools. Do you have any thoughts about how we enter these difficult conversations to move forward versus and not to antagonize or alienate people who are at the table and who make policies, help make policies?
Well, I think, again, language is important. You have to get to the root of it. But I also believe that it's a work in progress and it has to be both sides, right? So that's just like if you're trying to work something out with your spouse. If your spouse is constantly irritated by what you bring up, or they don't want to hear it or offended, how can you ever get anywhere? At some point, you have to be able to be willing to listen to the hard truths, be open-minded. That's why I have my box of knowledge. And understand that there is probably some information that I do not know, that I could have and should have, to try to make the world a better place, especially if you're in a position of power, right? So if you're giving out raises, how can you do that equitably? If you're hiring, how can you do that equitably? If you are in Congress, how can you work with sides to make sure that we're protecting rights? I think that what Raphael Warnock said was very profound. How can you guys want us to protect minority rights in the Senate and you don't want to protect them in the country? So sometimes these conversations are going to be difficult. If the conversation is difficult, then we must acknowledge that the lived experience is too, right? So it goes hand in hand.
I want to close out this portion with the thought that I'm a scientist, a biologist. So imagine that you have two plants and you grow them in a greenhouse and you bring them to your home. You put one plant, and they look very similar. They're from the same, they're siblings. You put one plant in the corner with very little light. You put the other one by the window, and the two plants grow differently. One blossoms with big green leaves. The other one just barely survives. And you ask, what's wrong with that plant over there in the corner? Why is it not flourishing? You can't blame the plant. It's the environment. It's the place that you put it. So I think if we look at what's happening in not only the US, but around the globe, and we look at the context in which things are and where we've come from, the historical biases, the systemic biases, the deliberate systems of inequities that have been put in place, we realize that we have a long way to go. There's a book called Lies My Teachers Told Me, which talks about some of this miseducation of the Negro and of others. So I encourage people to read, to teach their children, and let's all have an open perspective about how we get better. We thank all of you for coming tonight. Dr. Anderson, thank you so much for your candid presentation and sharing with us what you've learned over your path in medicine. I want to thank WISDOM and TrustMessengers for working together to start this series, this dialogue. We hope that it was recorded, so we're going to post the recording on several websites so that you can go back and get this, go back and get it and share it. We hope this won't be the last, but that it open up a topic, not to be angry, not to point fingers, but to say we're all subject to a history that has crippled our country. And the only way to fix this is to go back, understand it, unpack it, and systematically do the things continuously. It won't be a simple fix. It's not something you can do and say, I've arrived. It's going to be a conscious effort going forward of all of us to work on the things that keep us separated. because really we're all humankind, and that's what makes us who we are. So I want to thank everyone, and my assignment is to close this out in a prayer and then turn it back over to Dolores Lyons to have the last word. So if you would just for a moment go with me as we tap into the greater power, however you call God. Creator, Father, Mother, we're so thankful for this time we've had together. We're grateful for what you're doing in the land as you have shut down the whole world. There were tiny viruses that seemingly came out of nowhere, but you got our attention. You set us all down. You took us all out of our busy daily lives. You have our attention now. So Lord, we just come and say to you, have your way, that we may become the daughters and sons that you want us to be, that we may love you first and love one another as we love ourselves. And teach us to love ourselves. Teach us to understand that we're all on this planet Earth. It's going to take all of us using our best gifts and graces to solve the issues of the environment and so many other things. So now help us. Thank you for this talk tonight, this dialogue. We are yours. Have your way. And I ask this in the name of Jesus. Amen. Thank you so much, Dr. Anderson. All right, back to our wisdom representative, Dolores Lyons. Thank you.
Thank you. Thank you. I want to thank both of you, Dr. Fuller. This is awesome. There still were a couple of other questions that people had, but real quick, Dr. Anderson, if you can say what ACE stands for. That was one question.
Oh, adverse childhood events.
Okay, adverse childhood events, and why you don't use the term white supremacy when everything you have talked about speaks to white supremacy. If you can say that quickly.
Yeah, so I don't use the term white supremacy because I believe words have power. So supremacy means supreme. And we have to ask ourselves, we did not create that term and we don't have to necessarily use it. And we have enough intelligence that we can define things on our own terms. Again, when people hear white supremacy, they tend to think KKK, vulgar, nasty. The whole point of what I do is when I say deliberate systems of inequities is to make people realize that racism does not have to be vulgar, nasty. It can be subtle and it sits in systems.
Absolutely.
And that's important to realize that. So that's why I don't use that term.
And I don't use the term minority either for the same reason. So I just want to say the video of this will be posted on the Wisdom Space page, and we'll also make it a YouTube presentation from TrustMessengers. So look for it on the Wisdom Face page, which you can like, and also it will be made available as a YouTube from TrustMessengers. That's it for me. The next time will be phase 2, series 2 in this race and medicine discussion.
Yes, we're right on time. Thank you, ladies. Thank you, participants, and we'll see you next time.
See you next time. Be blessed. Take care of each other. Stay safe.
Have a good one.
Bye-bye.
Bye-bye.